So I'm going to be speaking about the diagnosis of pulmonary embolism. I have no disclosures. So here are my objectives in the 8 minutes, which is to focus on the imaging modalities for the diagnosis of PE and discuss really the strengths and limitations and some corrective measures for CTA. So when we talk about non-invasive imaging modalities, excluding Dopplers, we're basically talking about chest X-rays, VQ scans, CT pulmonary angiograms, and MRA. So when it comes to chest X-rays, a chest X-ray is not sensitive or specific for pulmonary embolism, but it's recommended for the initial imaging workup. And the main reason for that is it may uncover the etiology for the patient's symptoms, meaning if the patient had pneumonia and congestive heart failure. And very often what happens in at least in our emergency department is that the CTA order and the chest X-ray order go together. And you'd be surprised that if you call the clinicians and say, hey, your chest X-ray shows pneumonia, do you still want to go with the pulmonary embolism CT? Very often they'll say no. But very often, even in the setting of a pulmonary embolism, the chest X-ray is unremarkable. There are some sort of specific findings, which might be a unilateral pleural effusion or atelectasis, but those are also very, very nonspecific. But the most specific signs I'm going to show you in a second. And then the chest X-ray findings may impact the next step. So I'll show you here 2 X-rays from the same individual with ignore the bronchogenic cyst. So if we look at this image, you can see that the right lung is more hyperlucent, and this is not a pneumothorax, but in fact the Westmark sign, which is a hyperlucent or oligemic lung, and basically there's a huge clot sitting in the right main pulmonary artery and getting no blood to the right lung. And this is a nice angiogram depicting exactly what the Westmark sign is. So this is only one time I've ever seen this, and this is an uncommon thing to actually see. This is a little bit more common, which is the Hampton's hump. On this X-ray, we see a triangular or wedge-shaped opacity in the right lung. When we do the CAT scan, we can see that there's, again, a wedge-shaped opacity with some bubbly center. And without the contrast on board, this is very suspicious for a P on its own. But once we open up the box and we see the pulmonary arteries, we can see pulmonary emboli. So in general, CT pulmonary angiography is currently the imaging test of choice. It's a very quick exam with a 5 to 7 second scan time. It's readily available. And then since the introduction of multi-detector CT in the late 90s, the CT usage has really taken off. This is data from 2009, but there were 70 million scans around that time, and 4% of those were PE scans. And then just to tell you, the ED positivity rates range from anywhere from 5 to 12%, 12% being on the high end and from Canadian studies. This is a very important slide that I won't get into too much, but it has a lot of things to say. Basically, this is from JAMA, and the authors in this study chose 1998 as the year when really CT was introduced and studied based on ICD-9 data and death certificates, what happened to people or trends in pulmonary embolism and mortality. And basically what they showed was that once the introduction of CT, you can see that there's a marked increased incidence in the diagnosis of pulmonary embolism, but not so much of a decrease in mortality. And this is about the diagnosis of PE, not the overdiagnosis of PE or the overutilization of CT, but this is something to think about. One of the main points that the authors make from this is that many pulmonary emboli may not be clinically significant, and the potential harms from anticoagulation may outweigh the benefits of pulmonary emboli that may not kill you. But maybe you can talk about this later at coffee. Now I'm going to talk about what we look for. So we look for an intraluminal filling defect. It's as simple as that. When we see one, we say what caliber is the vessel. Is it the main pulmonary artery, the lobar branch, segmental or subsegmental? How many emboli are there? That's something that is very commonly studied. And when you talk about quantification of pulmonary clots, is how many different emboli you have. And then looking for other signs. So when we talk about right heart strain, I wanted to show you a movie of what it looks like. So this is a cardiac MRI, and basically what you're trying to catch in the CT exam is this in 1 second, so a still image of this. So on the MRI we can see that the right ventricle is dilated visually to the LV and the septum is flat and the right atrium is dilated. So no matter when you shot this picture on the CT, you would see that the RV was big, but as opposed in this case, you can see that in diastole the RV is visually bigger than the LV, but in systole it almost looks like it's not so big. So it's a tricky thing. So when it comes down to right heart strain, this is basically how you do it. You draw a line from the inside, the subendocardium to the subendocardium, and you measure the RV and the LV, and basically RV strain is defined as anything greater than 1. And it's highly sensitive, but it's moderately specific. And it's usually used in conjunction with TTE. When we talk about acute versus chronic, acute pulmonary emboli tend to be in the center of the vessel and expand the vessel, whereas chronic PE tend to be along the wall. There are other signs of chronic PE, again, mural-based, these linear webs and bands that traverse the arteries, and then the hardest one, which is just attenuation of the vessels in all of them. So reasons for a non-diagnostic CTA. So if you look at this image, you might suspect that there could be a pulmonary embolism in this segmental branch in the right lower lobe. But when you put this on lung windows, you can see that there's a lot of respiratory motion artifact. And this is sometimes called the seagull sign, because these look like the wings of a seagull. But when you repeat the study without the patient breathing, you can see that there's no pulmonary embolism. I'm going to skip the bolus trigger method. I think this is something that we're all aware of, but this is something that's commonly discussed and people are not so aware of it, which is another reason for a non-diagnostic exam when you don't have good contrast in the pulmonary arteries, and this is sometimes related to transient interruption of the contrast bolus. When people take a large breath, the intrathoracic pressure drops, the venous return tends to be more from the IVC than the SVC, and you can dilute your contrast bolus. And the solution to this would be to have shallow breathing instructions. Now this would be a whole talk in itself about Dualenergy. Quickly, I'll just tell you that Dualenergy is a hot topic where you basically use the different energies to analyze attenuations of different properties in the body. And what this allows you to do is basically create an iodine map, which is a perfusion map of the lungs. And you can see perfusion defects in the lung instead of actually seeing the pulmonary emboli. But this was a big paper that came out of the people in Sloan Kettering, and one of their conclusions was that out of 1,100 PE studies, they found 11 extra pulmonary emboli by using the iodine map, so it adds a very slight benefit, but some people absolutely swear by this. So what do you do with a non-diagnostic CT? Well, if the kidneys can handle it, I just repeat the CT. You can consider a VQ scan, you can treat reimage, and then MRI is not so commonly done. It's a long scan time. You have to have scanner availability, and the spatial resolution is not as good. VQ scans, here's a picture of one, is usually in this currently we're basically used for people who cannot get IV contrast. It can be used for pregnant patients to do only perfusion. If the perfusion is normal, then you can stop, and it is traditionally the test of choice for chronic pulmonary emboli. But there is always a differential. So you can have tumor emboli. This is a right atrial myxoma that embolize into the lung. You can have air emboli, and you can have amniotic fluid and fat emboli, which you tend not to see in the vessels themselves, but you just see the repercussions in the lung, which tend to be an ARDS type picture. And again, my last slide, remember there is always a differential, so this looks like a big pulmonary embolism in the right main pulmonary artery, but if you look, maybe it's a little suspicious, there's really nothing going into the left, it almost looks like it's expanding the pulmonary artery itself. When we did the contrast MRA, we can see that this enhances post-contrast, and when we did the PET CT, this is lighting up like crazy, so this was a PA sarcoma, and this patient had a pneumonectomy. So in conclusion, CT is a quick, available, and accurate test. The benefits include RV strain evaluation and identify other cause of potential symptoms like in the lungs themselves. So thank you very much.